Okay.
Perfect.
Right.
Hi everyone. Thank you for joining this webinar on keeping services safe during COVID-19. My name's Jem and I'm the Deputy Programme Manager on the Quality Network for Forensic Mental Health Services at the Royal College of Psychiatrists. Today we have Helen Smith, a Consultant Forensic Psychiatrist, and Nakul Talwar, Clinical Director for Secure Services, both from Devon Partnership NHS Trust, to talk us through this topic. We would like this session to be as interactive as possible, so you'll have the opportunity to ask questions to Helen and Nakul throughout using the Q&A function in Microsoft Teams Live. We'll do our best to get through as many as possible, but we apologise in advance if we can't get through all of them. Also, just to make you aware, we'll be sharing a recording following this webinar on our website for anyone that's not able to join it. And we really hope you find this session useful, and I'll now be passing you through to Helen and Nakul.
Hi, good afternoon all. My name is Nakul Talwar and with me here is
Helen Smith. Hi everybody.
So we are using this forum as an opportunity to talk through our journey as a secure service. Now, this is by no means suggesting that we are experts in this area during the current COVID crisis, but rather just sharing with you our experience, and certainly would be more than happy and would like to, if anything, learn from you in regards to what your experience has been, and perhaps if you've done something differently in your service. So we are we're part of Devon Partnership NHS Trust, and we are a secure mental health service within which we have inpatient services and community arms. Within the inpatient service, we have medium secure, low secure, and open beds, which allows a flow of patients, supporting them in the least restrictive environment within our service. More recently, we have developed our community forensic team alongside with the specialist Pathfinder team to support individuals with a personality disorder, the intellectual disability community forensic team, and the offender personality disorder service through our local prisons. So we work as part of a much broader pathway in regards to facilitating transfer of patients between the service and supporting them. Now, before we talk any further about what we did, it might be helpful for us to tell you a bit more about our service. So yes, this is what we offer, but we sit on a wonderful and beautiful 110-acre site in Devon. Here, as you can see, we're trying to give you an idea of where our site is based. It's very green. We have very, very large grounds, which obviously puts us in a slight advantage in regards to how we could utilize those grounds, especially under the current circumstances. We appreciate, of course, that some of the things that we have done out here or have been able to do out here may not be things that could be replicated in other services. However, perhaps the principles regarding what we have been doing might be helpful to others. So before telling you, or rather going through our journey, I thought it might be helpful to explain what I think would have been really, really helpful for us to be clearer about 8, 9, 10 weeks ago, really. Now, although we were relatively early in this journey, as we have the advantage of learning from other colleagues elsewhere in the country and elsewhere in the world, we perhaps underestimated, I certainly underestimated, the degree to which the current COVID crisis would take a course. Now, my personal experience has been that over the last 9 weeks, essentially, the journey has been in different phases. The first phase was that of a acknowledgement, or rather an absence of acknowledgement phase. And this was a particularly difficult time where we were struggling to be able to communicate effectively to various colleagues, including various senior clinicians, regarding the potential impact of COVID on us as a service and us as a society. And that was the phase 1, which required a lot of support, a lot of education of staff, patients, families in regards to the potential outcome of this journey. What followed after that was perhaps what's referred to as by us at least, as the adrenaline phase, when people were initially able to perhaps better understand the potential impact of COVID that we went into a significant drive whereby we were doing everything in seconds and minutes rather than weeks and months. Now, of course, that came with a level of risk acceptance, but it was then followed by where we find ourselves currently. This is perhaps the more anxiety phase, where we are in a place right now where we do not have any patients with COVID on our site. We haven't had any positive cases so far at all in either patients or staff who have been tested. And this has created a sense of anxiety, essentially, whereby what now? Where do we go from here? Especially as at the government level, there are discussions happening in regards to how do we lift the restrictions. So this takes us to what's likely to come next is the ambiguous or ambivalence phase, where actually we're not really sure where we go with this. How long is this going to last? No matter where it goes, we probably will finally reach a stage of acceptance, whereby we need to think about how this has impacted on us as a service, us as a society. What do we take from this? And actually, what do we keep and what do we let go from our learning? So recognizing all these things, I wish what we had really done 8 weeks ago was two key things. Be absolutely clear and shout about what is going to be our communication and our implementation strategy. As all of you probably have experienced in the last 8 to 10 weeks, the number of emails in your inbox has gone through the roof. In addition to the information that's coming in your NHS Net email address, you also are probably looking at WhatsApp, news apps, and so forth, with multiple sources of information that are essentially conflicting. And I wish, certainly within our service, we had recognized that to that degree, and right from the outset done perhaps what we have done over a course of time. So what did we do? So we were very fortunate that we actually had a relatively robust structure within our directorate. Some of the terminology that we use, understandably, is idiosyncratic, and is something which I will try and go through and explain. We have what is called a DOM, which stands for Directorate Operational Management Meetings. They happen 3 times a week on Mondays, Wednesdays, and Fridays. And these existed prior to COVID as well. What we did was essentially, rather than developing new structures and new systems, we upcycled our current systems. We are very fortunate in that we have a medical group that meets weekly to discuss cases, complexities, progress, and of course, mutual collegiate support. We have multiple patient engagement forums, including with other stakeholders, such as families, aftercare providers. So we already had good relationships with various parties, but it was about how we could use those forums to avoid confusion within the directorate during a time of essentially chaos rather. So what have we done? And this is by no means suggesting that we've got it absolutely right. We are learning as we are going on, and what I'm about to describe to you has occurred over a period of time, not overnight, albeit largely in the last 8 weeks.
Nearly overnight.
I think that's very fair to say. Now, what I mean by that is that, so this meeting I was referring to earlier, the DOM, which is on Monday, Wednesdays, and Fridays, we've utilized that as a forum whereby we receive information into one email inbox into our service. We use that very inbox to communicate to the directorate, within the directorate, and out of the directorate. And that's where we receive information and communicate information out. This is with a view to minimizing any confusion for others in regards to the multiple sources of information that is being received by all parties here. The emphasis of these meetings has changed. The forum remains the same, But this provides the opportunity that following that meeting in the directorate, in the service, we take that information fresh to the shop floor where we have patients and staff, essentially awaiting that information that is being communicated within 2 hours of that discussion in that forum. That happens 3 times a week, but it also provides the strategy for information to come from the shop floor back to us. Within that, there are actions in regards to sharing that information with families, with aftercare providers, with other stakeholders, including our commissioners, to ensure all understand where we're going with this information. We recognize the fact that, of course, all staff are present during those forums, but sometimes they may feel that they can't share that information or express their concerns in that forum whilst others are present. So we offer them a separate opportunity on the ward itself, specifically for a staff forum, for them to actually be able to discuss or clarify any issues at all. It's all sounding very easy and all wonderful. It's not. It's not been that easy at all. It's been a very difficult and challenging journey, and this is something which we are getting better and better at, and we have not perfected it. What were the basic principles that we were applying in regards to our strategy, in regards to our communication? They were essentially twofold: prevention and protection. And prevention encompassed everything that you can think of, everything which I'm sure all of you have done in different shapes of form. I don't think it was until 12th of March that the WHO described COVID as a pandemic. Our working in prevention had already started in late February. Now, that is not to say we completely recognized and got it right. Rather, that's when the process started. The process of ensuring that we were doing hand washing prior to entering the service. I think over time, we've introduced masks for all staff working on the service. The premise, of course, is that COVID will be brought onto the wards by us as staff, not from the patient group, largely speaking. And as part of that, we'd introduce significant restrictions from leave, for example. We restricted leave to our site alone. There was no more community leave. We brought in restrictions in regards to the number of people who could go on leave at any given point in time, despite being on a 110-acre site. So this was being managed extremely carefully in order to reduce the likelihood of cross-transmission. The other areas we've obviously been moving forward with is things like wearing scrubs. As you can see, both Helen and myself are dressed in that right now. We were doing absolutely everything to reduce footfall, and that was from day one, from staff, from those, from essentially visitors, and essentially also from other agencies, including second opinion approved doctors. And we were rather unpopular, to be fair. I think where one had to literally go out of the unit, explain our position, discuss with the CQC in regards to why we are doing what we are doing. But in general, there was a level of acceptance as to what we were doing and why we were doing it. Indeed, we recognize the fact that subsequently, of course, various agencies have moved to remote working, and that's something which we had applied very quickly. So what's the second part, I think, in regards to our strategy was protection. So largely, we've been very fortunate that we've not had to apply our protection principles so far. Now, what was it about really? So this is where we're talking about reversing the risk. So I talked to you earlier about the risk from staff to patients, but now we're talking about protection in regards to both staff and patients, including risk from patients to us. So this is about recognizing that as there are admissions and discharges, there's an increased likelihood of COVID being identified or patient being COVID positive on our site. So in addition to all the policies and procedures that we implemented, we developed within a matter, and you hear about this a bit more later on, an isolation unit within our wards. We prioritize which services are key, and recognizing and appreciating the fact that all our services are important, there were those which were a bit more important as we felt compared to others. We were looking at cohorting, not just necessarily for patients, but also for staff, and thinking about cohort in its genuine sense of the word in regards to what can we do to minimize risk, and of course, shielding some members of staff. That does not mean we excluded them from being able to work, and I'll talk a bit about that later on. We looked at how we could create this isolation unit through supporting patient flow, from the point of admission to the discharge, identifying through all disciplines where supportive interventions could be included in order to facilitate discharge in a safe way. Now, this slide is essentially talking about balancing and applying the principles of proportionality. So the more restrictions we applied, the more we felt we had to introduce within our setting, within our wards, within our site. And this was perhaps one of the most challenging tasks. But we were very fortunate that actually we received a huge amount of wider multidisciplinary support. It was genuinely humbling to see how people during this difficult time came in and were more than happy to help in any way they could. We had support and learning from not just colleagues regionally and nationally, but also from our colleagues in Australia, Singapore, Hong Kong, in regards to their learning and what their services were doing, not from just a medical or service perspective, but from a wider perspective in regards to occupational, social, psychological, to support patient and staff well-being. We used the principles of that and started applying that in our practice, in our service. What that meant in practice was requesting staff to not just fill shifts, rather getting the support to do their work in a way on the ward or supporting patients come off the ward on our side with the ongoing engagement in therapy. So we have a sports team, we have an occupational team who have been supporting deliver this alongside with the psychology team and our social work team. They have been working incredibly hard with, of course, our nursing team who are working tirelessly on the shop floor. So this is a bit about building an isolation unit. Now, as you probably know, that developing units takes years. What we did was create a physical build within our service in 10 days. This is with the support of our estates department, our security team, who were incredible in helping us devise the relevant procedures, identifying the relevant stock with the procurement team, and of course, our incredible staff who were willing and put themselves forward to work on the isolation unit. We've had significant difficulties in thinking about what is the right level of PPE, and I'm sure that's a point of discussion for every service in the country. Is something an aerosol generating procedure or not? I'm sure that debate continues. But what we want to do is we want to ensure that we work with our staff with understanding their anxieties and thinking about what they feel also safe with, given the conflicting advice, especially between, I guess, the Resource Council and Public Health England. As part of that, we had to think about, as I mentioned earlier, a patient mobilization strategy. So how are we creating this unit whereby actually only this unit would be specifically for patients who develop COVID within the service? We gained the support of our community forensic team, who were incredible in supporting us support patients being discharged from the service to the community with an immense amount of support. And Helen will talk a bit more about that. All this happened based on consolidating on our existing good relationships. That was a huge and key learning point, is about maintaining good relationships. Staff well-being, alongside with patient well-being, was the heart of what we've been doing. So essentially, I spoke to you earlier about our incredibly hardworking staff, nursing team, support workers on the shop floor, being supported by the wider MDT. As part of that, we had to ensure the fact that they had a safe space to be able to walk away from the ward, given the immense pressure on them. We've introduced extra breaks for them on their shifts to ensure they feel supported with MPD support. This is something which is interesting and very controversial, the idea of job planning in leave. Whilst we're amidst this COVID crisis, and as I talked about the adrenaline phase earlier, we are rushing all the time, and our fear is that we will come to a place where things will become tiring. People will burn out, and we don't want them to burn out. So we're essentially devising a strategy of a period of a quarter of job planning, where we essentially include leave within that to ensure staff well-being and supporting them during that period. We have a health and well-being lead who is going across the wards. Now, this is something which we normally don't do. We try to minimize cross-transmission. And one of the things we've tried to do is try and even reduce the footfall between our medium secure, low secure, and open services. So of course, we're doing all the remote working and using virtually every platform that you can think of, like all other services. But we felt that on balance, this was an extremely important part, obviously taking into account the relevant infection control measures. Their hydration units, spaces rather, donning and doffing off stations to reduce the risk of cross-transmission. And as part of that, we obviously, as I mentioned earlier, introduce all staff ensuring they're wearing masks before they go into our inpatient service, and the use of scrubs. We talked about staff support earlier, and it's important that they have a safe space to be able to voice any concerns or anxieties they have or seek clarification. So in separate to the patient forums, we had reflection meetings on various wards to allow the staff to be able to have those discussions.
And I think it's time for a break now. So we wondered if there are any questions available now. We take them quickly, and then we do the second half of the presentation with questions again at the end.
Yep. So one of the questions is, how are you planning to reintroduce Section 17 leave for patients?
Oh, wow, it's a fantastic question, isn't it? And I think it's perhaps going back to that stage I was referring to earlier in regards to this anxiety and followed by this ambiguous phase. And I think one of the things certainly we've been thinking about as a directorate is, how do we do this? And I don't think there is necessarily a right way to do it. And I think what we've acknowledged as a service is there's potentially a wrong way to do it, which is open the doors completely in one go. But we think there are different right ways to consider, and I think we need to do this in a risk-balanced approach. So what we were thinking about was, at the moment, all leaves are from individual wards, where essentially patients between wards are also not having contact with each other. So we're going to do this in a graded way, whereby perhaps the first stage may well be that the patients between different units, or at least sister units as we call them, are able to interact, and we assess the efficacy of that. The point prevalence, I think, as we've calculated in our service, and I say service as in the Devon Partnership as a whole, is 0.4%. So recently we did a whole host of swabs. I think we did about 456 in the trust, and there were 3 positives from asymptomatic staff. So within the security directorate, it was 0. So I say essentially our prevalence rate is pretty low. So what we would try to do then is introduce those patients mixing in those wards and doing group leaves on the site itself. And then introducing ward by ward to the more local community leave to assess the impact. That will have to be associated with test. And I think it's really important, the fact that you have that provision available to you as part of your strategy prior to going for that aspect.
Okay, thank you. The next one is, how are you managing PPE and face masks with patients who may have past trauma who find this extremely distressing?
Thank you, and I think that's something which I ought to have covered in the presentation earlier. So you are absolutely right. As I said, we did not do everything overnight. So first what we did was, in fact, we actually had a mandate to introduce the masks earlier than when we actually did. But we fought that, taking into account exactly the concern that you've highlighted. So as part of that, we actually took an approach whereby we actually wrote to our patients, but through those forums I identified earlier, offered the opportunity to discuss this with them. We talked about what we looked like before the mask on, and with us the mask on, and what we looked like, and how difficult it is, and why we were doing it. We clearly highlighted that this was actually not something that we recognized the fact that we were going to bring COVID in, and this was to protect them rather than necessarily protect us as service providers. And yes, it's fair to say that there were some anxieties, both from staff and patients. And for anyone who hasn't worn these masks, they are really uncomfortable. Try wearing them for 4 hours. Good luck. It's awful. It really is. And it's interesting because initially there was some anxiety from patients in regards to finding it quite difficult. Over the last few weeks, what I found is that actually my patients are asking me, are you okay behind that mask? You know, are you really sweating? Is it really uncomfortable? And it's allowed to have this dialogue, and I think it's been really interesting and very helpful, in fact. So yes, initially there were more anxieties, but actually over time, what we found is that I certainly personally am not aware of any significant concerns still being maintained by either patients or staff over this period of time.
And I think I'd add into it, we've really proactively managed it. So we've had loads and loads of time talking to our patients about it in our forums. And actually we create forums like, so on my ward, I'm on a complex care acute admissions ward, and we've done a piece of creative writing with patients so that people can talk and express what they're thinking and feeling about these sorts of things. So we're incredibly mindful of it. And it has really, really surprised us actually how grateful patients are that we are taking responsibility for not bringing COVID into the unit. And as Nakul was saying, actually, the patients are acutely aware of the discomfort that we experience. You know, they worry about us in the context of having to wear the mask. I think for me, the most tricky thing is I use my face all the time when I'm talking to patients and trying to diffuse difficult situations. And I think I'm not alone in finding it very challenging for patients only to see my staring glass-ridden eyes. So I think that has been quite a challenge, certainly on our acute admissions units.
Mm-hmm. The next one's slightly similar, which you've partly answered. So when did staff start wearing the masks, and also are patients offered them?
So no, our patients are not offered them currently for the reasons I exactly cited at the moment. It's actually to prevent the risk of transmission from staff to patients, not from patients to staff.
Mm-hmm. Okay. Next one's from someone who works in a DBT inpatient service and wants to know how are groups managed in other areas.
So yeah, I think that's really a good question. So I think, I'll be honest with you, I think we got it wrong to start with. So initially when we started, we were trying to reduce footfall and we were reducing groups as such. And what we learned over time was actually it was having a more negative impact than positive. Being mindful that we've not had any COVID positive cases inside, we reintroduced groups with social distancing measures. But we are very fortunate, especially in our medium secure services, a relatively new build. It's very high ceilings, very bright, very light, a lot of space, so we can still facilitate those groups. And I think, yes, the feedback has been incredible. They've not just been psychological groups, I guess by virtue of what they are, have a psychological basis in regards to therapy, but equally in regards to sports groups, occupational groups as well, that are still ongoing as well, indeed.
And just to add in, so our patients have been involved in the virtual world as well, and we had our first patient council, which we have across our site on a monthly basis, virtually from all the wards, which actually was a tremendously, slightly nerve-wracking, but very positive experience for the patients. And actually the patients who chair it and co-chair it were saying what a useful, it maintains its usefulness in that form.
I understand it was the best attended patient forum.
Yeah, so there's lots for us to learn from that. I'm wondering if we should move on. There will be time for questions at the end.
Yeah.
So in my bit, I'm going to talk about a couple of things. I'm going to talk about our community teams. I'm doing this on behalf of Paul McAllister, who is our community consultant, who's our other CD, who can't be with us today. So I'm hoping Nakul will take all the questions on that. And then I'm going to go on to talk a little bit about some of the work. One of my other roles is I'm the National CD for the Mental Health Safety Improvement Programme with NHSI. I'm working with colleagues at the college in the NCCMH and CCQI. I'll share with you a network that we've introduced that some of you may be aware of, and if you're not, you will be by the end of this. And the last bit, just some really simple practical stuff that we've been doing at ward level to try and manage some of the difficulties we've run into in the current conditions. So starting first with community teams. So I'll just give you a little bit of background. Our community teams are relatively new. Down in Devon, we're really short of forensic psychiatrists. So at the time that COVID hit, we had a 40% vacancy on our site. So we were already covering far more than any of us would originally want. And so when planning how we managed our community time, we had to be very mindful that our psychiatric resource is very precious. So this has very much influenced our decisions. The forensic team, as I say, was relatively new, and actually they have already got quite a good forum in place, or structure in place, for ongoing OD and management within that team, which I'll talk about in a minute. The other thing to notice is that we are, so Devon is the third biggest county in England. To get from the top to the bottom of the county, even on a good day, takes at least 2 hours. So we've got some significant challenges in how we support our patients who are out there in the community. So the new infrastructure in light of COVID. The first is the vast majority of our prison assessments are done remotely, and this very much is preserving our psychiatrists. So psychiatrists do go in, but rarely. In fact, we cover 3 prisons across the Devon cluster, and our main remand prison, actually, the consultant who's responsible for that input, the first time he went in was actually on Monday to do a couple of assessments. There are a couple of environments within the prison that we can't do remote assessments in, so we will be going in to see people in those. Secondly, the community team has been set up in such a way that they have a role in commissioning their providers. And so they have regular contact with their providers and provide supervision within those settings. And so once again, we'll talk a lot through this presentation about relationships, but so they've got good trusting relationships with the people that are providing care for the population that they are supporting. The other bit of learning that the community team had was that when this crisis first hit, there was we were told everybody should be doing home working. So everybody went to their homes to do their home working. But then we realised that actually home working for some people is incredibly tricky. So a lot of our team are very young, they live in flats with perhaps another person or two who do similar sorts of jobs themselves, but they don't have loads of space, don't have lots of opportunity for confidential spaces. And so what we decided to do was to start looking at how we use our own community facility here, but there's loads of properties around the trust that don't have people in at the moment. So being very creative about how we find space for our people to be, and that has worked extremely well for that team. And the other thing that has been really important to keeping them, I mean, they are managing probably the most complex clinical conditions at the moment across our secure services. So they have really maintain their continuous learning. So they had, as I said, a partner, an OD partner that they were working with for team development. They carried on doing that actually, and they've had they did a big virtual session with their facilitators a couple of weeks ago, and that has been very important for the team, as well as they have regular opportunities to virtually meet up too. Now I'm just going to talk a little bit before I go on to the ward stuff around what we're doing at the college. So people may or may not be aware of this, but we've got the Improving Mental Health Safety COVID Mental Health Improvement Network, Anybody who's interested in joining, please email us through the email address that I've put up there. And anybody who likes a bit of Twitter, that's our hashtag on there, and we use Twitter a lot, want to pick up projects, but also to share with people great ideas that we've come across that people might like to test or try themselves. For people who are familiar with CCQI, so this is a joint venture between CCQI and NCCMH at the college, and we use the Knowledge Hub to host this network. So please do have a look. We've tried to make it absolutely as easy as possible for everybody. So don't feel inhibited because you run off your feet at the moment and you don't have time to share an idea. We make it as easy as possible to share things so that we can get your brilliant ideas out there across the network. And we've had an excellent response. And last time I looked, which is well over a week ago, we had over 500 members, and we have members from across the world as well as the UK. Just to give you an idea of some of the stuff that goes on, so we put up, you can see our little pro forma. So we ask very simple questions. What's the problem you're trying to solve? What did you do? How did it go? And what did you learn? And what advice would you offer to others around setting up the various projects? So there's projects up there, but we also share other interesting things that we find on the network. So please do take a look. Now I'm going to talk about some of the little improvement ideas that we got up to in Secure Services. So I think even more than ever, we've used our clinically focused regular discussions on the ward, and if I'm really honest, on my ward we weren't that robust on it before this all started, and now it's become incredibly important. So Nakul talked about how we mobilise patient flow through services. So my ward our ISO unit is actually on our acute admissions ward, which basically more than halved the number of beds we had on that service, so that some of the patient flow came through next door into my unit, which I share with Sam Kadri, the other consultant. And so we all of a sudden got an influx of people who were still more unwell than they probably would have been previously coming to our ward. We had a lot of patients move all at the same time, as well as a lot of staff moving around all at the same time. So you can imagine it's quite a toxic mix in a secure service. So this clinically regular focused regular discussion has been very, very important. We also looked very hard, and I'll talk a little bit more about this, about the ward infrastructure, both for our patients and our staff. I think one of the things that really surprised me actually right at the beginning is, I'll talk about an intervention in a minute that we put in place, and we didn't have it completely reliable at the beginning. And I had a couple of patients just come up to me and say, you know, what are you doing? You know, don't start things if you're not going to finish. You've no idea how important structure is for us at the moment. And so it was great to be held account, actually, and to really get that sense of view from people. And it also spurred us all on a bit, because none of us like to be told we're useless. Yeah, so relational security has been our biggest issue, I think, in maintaining and improving that as we have changed our services very, very quickly. I just want to, Nakul's talked about this a little bit, but one of the things we've absolutely done is maxed out ward activity. So we're already very lucky in that we have some amazing sports team, a fantastic OT team, a great engagement and involvement team. So we just maxed out whatever we could on the unit, which has been hugely appreciated by patients. And just at a very, very grassroots level, some of the things we've done, just to give you some ideas, is by no means perfect. So QI is my thing, and safety, so I love testing and trying new things. I've known about safe wards for a very long time, and also stuff around reducing violence. So we did some work with SLAM a few years ago, 4 Steps to Safety. It's been a really, really good opportunity to get some reliable implementation of that. So Safe Wards Mutual Support Meeting, fantastic forum. Dead easy, half an hour every morning, staff and patients getting together, 4 subjects, talking about thank yous, news, support, what are the offers today. That has been fantastic on my unit for getting information to and from patients and to give great structure. And there are other things from Safe Wards that we're currently trying. We've had maximum flexibility about using our leave. So Nakul spoke about, we're lucky we're in our huge site. and it's a huge, beautiful countryside with lots of wildlife, lots of trees and plants. So we've really maxed out how we can use ground leaf and put in, you know, bird watches, animal watches, photography, all sorts of things to make that leave as purposeful and pleasant for people using it. We've got our engagement and OT team have got a daily positive newspaper, so it's very, very easy to get very stuck in very negative news about COVID, and that just brings everybody down. And so our patients have really appreciated us talking about some of the positive things as a result of COVID. And so we started off with a presentation that one of my my Fab OT did, and then moved on to we're going to have we have already a newspaper around that, which has worked very well. And the other thing that really freaked me out a bit when we first started moving people around is you suddenly realise we manage really complicated people, and you really need to know our people well to make sure they're supported well whilst they're using our services. So we developed some top tips for supporting somebody. So it was just a side of A4 with somebody's photo on, a little bit of background history, and what are the top tips for really supporting this person well, and also what are the positive ways of engaging this person well, so that anybody could walk onto our ward who hadn't been here before and could really get to grips quickly with how to manage some of our complexity. We're also working towards this with meds, because we have, as you can imagine, on an admissions unit with people who are less engaged in managing their own mental health. We have some issues with meds administration and med compliance, and so we've done some top tips around that. And that, I think, staff coming onto our ward tell us they found that really helpful. I'm just jumping ahead of myself. And one of the things that we picked up from, it's probably from acute colleagues actually, through the quality improvement stuff we've been doing, is a wobble room. So I think, as Nakul says, we're through the honeymoon period on this. We're now in anxiety, and our units are getting more disturbed as people, the reality of what's actually happening is really setting in for everybody, and that's staff and patients. And on some of our wards, we're managing extremely complicated mental health problems, but also with significant physical health problems too, which has been quite challenging for people. So a wobble room, which we stole from the acute sector, as I say, is a space essentially where our staff can just go, yell at the walls if they want to, but there'll be a variety of things in that room to help them to chill out a bit and to relax a little bit, if either in their breaks or if things get too much on the ward. So they're just a few ideas, and I'm sure people have been trying loads of others. So back over to you.
Oh, right. Okay. So yeah, so this is an interesting one. What is it that you keep from this? So COVID, or certainly our response to COVID, has been associated with a lot of interventions, and yes, a lot of them happen overnight. But what is that we want to keep? So I guess one of the things I would definitely want to keep is the learning in regards to a major incident. How do we as a service have a strategy of communication and implementation that we can learn from this particular run, and in the event that we have to apply it again, we do so. And I say that because, as I said earlier, we're in this ambivalence phase or anxiety phase right now, because we don't really know what's going to happen next. You don't know whether there's going to be a second surge or how things happen, whether you leave restrictions. Do you have to reintroduce restrictions subsequently and so forth? So actually, once you know the systems and structures, you can reintroduce them very quickly. The other thing, obviously, is recognizing that not everything has to take as long as it has in the past. and I genuinely mean that. And I think this has created the opportunity to encourage others to think like that as well. You don't have to sit on something and keep thinking about it and keep thinking about it. There has to be a level of risk acceptance in some of the things that we do. Also, the fact that not every meeting has to be in person. Yes, there's definitely a space for virtual meetings, especially in a place like Devon, where, you know, as Helen said earlier, the geography is so wide that actually, you know, on a good day, just going from the top part to the bottom part of Devon alone takes you a couple of hours. It doesn't make sense doing that for one meeting. So actually, certainly, I think using the various platforms that are now available, you know, suddenly overnight, are something definitely worth keeping. But I think for me, the key thing here, absolute key here, is to recognize all the stakeholders and to maintain that relationship, maintain that dialogue with them, and especially with our patient group. I personally think some of the forums or the frequency of forums, perhaps we don't want to keep to the same degree in terms of frequency, but certainly keeping that forums alive in regards to bringing information fresh from a management meeting to the shop floor and bringing the information back is absolutely key learning from COVID. Which brings me to things which we don't want to keep. Despite the advantages of virtual meetings, I'm not sure about others, but I'm Skyped out. I really am. And I don't want to look at another screen again, ideally. So preferably, in fact, for me, there has to be a recognition of the importance of social interaction and being in a room and being able to see someone's face and the response. Because one of the things I found is that we are not as nice to each other when we are virtual than we are there present in person. And that's really important to maintain those relationships. You have to be able to see and feel the environment where you are in, with sharing with that person in order to make it successful. So where does that take us finally then? I guess is the last thing is this, what's happened with COVID is this energy that it's created. It's created a sense of anxiety, but it's also created a sense of excitement at the same time. And I think it's created a sense of opportunity for innovation. And I think we certainly have come up with very different practices to what we normally would do in a very, very short periods of time. We haven't got it right every time, but it has been associated with the level of risk mitigation, risk acceptance, such that we ensure that whatever we are changing is not necessarily, well, it should not be associated ideally with a catastrophic event, but recognizing the fact that actually there's a level of risk acceptance which goes with some of those interventions. And
I just want to add to that. So one of the conversations we've been having at the DOMS, the clinically three times a week meeting, is being very explicit that it's okay to fail, that we need to be kind to each other, that actually we're going to try loads and loads of new things, some of which will work beautifully and some of which frankly don't. But we're not going to get cross about it. We're going to accept it and move on and take the learning into the next iteration of whatever we're trying. And I think that's worked really well, actually.
Yeah, I agree. And perhaps the most important thing, perhaps that everyone in school perhaps need to hear from coming out of COVID-19, is that Devon's the place to be, right? I think you need to recognize that we have the lowest number of cases countrywide. I've said it now. There you go. It's there. The cat's out of the bag, right? Okay, we have huge spaces here, beautiful lawns, wonderful sight, and the seaside around the corner.
And the squirrels.
Exactly. Why would you want to work anywhere else? I've just got some extra points for my chief executive there as well now. There you go.
So thanks, everybody. That's all we were going to say, and we look forward to having some questions.
Great. Thanks, guys. So the question is, how are your reflective meetings taking place whilst maintaining social distancing?
So we on each of our wards we have a large meeting room, and we have with every room in the building where people can congregate, we have a maximum number on the door of people we allow in, estimated on social distancing. So our big meeting rooms, we have a maximum of 7 in, but we also have a Skype set up. So people, so we have people in the room, and then we have people who join us through Skype. And the other thing that we do, and this is really important, is that we get as many people as we possibly can into the reflective meeting, and in order to do that, the wards and the multidisciplinary team all help each other to effectively free up as many people as possible to get to those meetings, and really having those as of primary importance for those working on the shop floor.
If I can just add to that, I think just reiterating Helen's point here, essentially, that we recognise the fact that not every unit is going to have that space available to them, but it's really recognising the importance and the principles of those meetings, and whatever you have to do in being creative to create that space to make those meetings happen, make it happen. They are really valuable. They are genuinely valued, so do make them happen.
And it's true also, I mean, the community team are doing exactly the same, and they do it completely virtually.
Okay, thank you. So how have you altered how you manage seclusion reviews, and are you using remote reviews?
Right, so it's interesting. When was it end of February, one of the first documents I was asked to draft was exactly that. So amending our procedures with a view to reducing risk of cross transmission was about looking at remote reviews. So yes, we did incorporate that in principle. We have not had to apply it. So yes, seclusion reviews are still being done in person as things stand, but we have an amended policy that allows for remote reviews to make that happen as well. I mean, it's part of this. It's interesting because I was talking about some members of staff being shielded. So what we did was, say a particular member of staff, consultant, was shielded, we still allowed her to be on call, but with a consultant buddy, such that if a seclusion review was necessary that particular night, the buddy would support the consultant to come onto the site if necessary.
And I think that's I think it's worth expanding a little bit on that. We recognise that this is a really stressful environment for all of us, including consultants, and all of us, recognise that we're more stressed than normal. So we have quite a good buddying system for when we're on call, and it's because we're dealing with quite significant physical health problems as well as mental health problems on our site at the moment, with limited support, obviously, outside. So we have, and this is builds really, we've got really good relationships between us all. We might not get on all the time, but actually we have a robust structure. So there's never been a problem for somebody budding. So for example, I'm on call for the next 3 days, and I've chosen to do the whole on call because I just want to get it out of the way. However, if it all becomes stressful and too much, I've got 3 consultant colleagues who will swap out with me if I need to swap out.
The reality is we're not going anywhere.
No.
Great, thank you. Next question is, how are you managing violent incidents in terms of restraint?
So I think, frankly, there's been no change in practice.
Yeah.
That's exactly the same as normal.
And of course, we're all wearing masks on the ward, which is unusual.
Yeah.
But otherwise, exactly the same.
Yeah.
Okay, so the next one is, so previously you mentioned that staff are the risk to patients, but also identified that no staff have had any COVID symptoms or positive results. So what is it that staff are doing differently outside of the hospital environment to not have contracted the virus?
So I think one of the things, one of the things that's very striking here is that people have taken it really seriously. I am so impressed by my whole team that actually we really go home and don't go out. People are very, very good at sticking to the government guidelines. The other thing that I think is really helpful, across the road from us is Sainsbury's. This is Sainsbury's Dawlish. So it's not Sainsbury's Central London. So actually, there's a special NHS time, and I do my shopping, everybody, at 7:30 on a Monday morning, where there's only NHS staff, and to be honest, it's not that busy. So I think we've been dead lucky in the point of view that we live in a less populated area of the country. But I do think, I don't want to minimise how seriously our staff have taken this.
I think you're absolutely right. And I think it's also the fact that we have an advantage here, in the sense we have that space. Majority of our staff coming to the hospital do not use public transport. Yeah. The majority, in fact, are driving. So I think all those practical challenges that might be applicable elsewhere in the country perhaps do not apply out here. We did, I think, create, as I mentioned right from the outset, one of the things we did back in February, in fact, was recognize the issue of acknowledgement, or rather absence of acknowledgement, regarding COVID. So there was a period we spent a fair amount of time in educating people about it. And actually, the whole idea of hand washing and social distancing is something which they've applied relatively strictly here in the hospital, compared to other areas that I'm aware of.
Yeah, and we started miles earlier than everybody else. We were the first. We could see this coming because of our connections outside of the organisation. So we started stuff going earlier than anybody else in the trust, just because it felt like the right thing to do.
Okay, thank you. Now this is the last one, which will probably take us to the end of the session. It says, thank you for the great presentation. What are your thoughts about the particular risks to BAME staff and patients?
Wow. Okay, so it's interesting because obviously the trust organised a BAME event. There already is a BAME forum within the trust, and there was an event earlier this week, as well. further to the government statement in regards to recognizing the particular risk identified in BME staff. And what's happened since then essentially is that a further risk assessment screening has been sent out to identify particular concerns for that staff group per se, with a view to identifying with the managers how the risk can be reduced to them as individuals, whilst being allowed to obviously support them working, whether it's in the site, whether it's from home, or whether it's in the shop floor. So obviously each person is being dealt as an individual rather than just as a group per se.
Okay, well, that's all the questions. I'd just like to say a massive thank you to Helen and Nakul for an extremely informative and really useful session. And just to let everybody know as well that, again, that we'll be sharing a recording of this webinar on our website in the next few days if anyone was not able to tune in today. And just that we'll have other webinars lined up in the coming weeks, so just to keep an eye out on those. But yeah, thank you again, Helen and Nakul, very much, and take care everyone and stay safe.
Thank you. Thanks for listening.